Thank you I would definitely like to thank Dr. Ullas Batra and Dr. TP Sahu for a very, very engaging debate. And that has made my job a lot more easy than what I expected to. And with due respect to Dr. TP Sahu and all the relevant points that he made over the next 15 to 20 odd minutes, I would like to try and reinforce what Dr. Ullas Batra, the point that Dr. Ullas Batra tried to make, which was how do we manage our patients with EGFR mutation in advanced non-small cell lung cancers, and what is the best way of getting them the best possible outcomes. So I hope my slides are visible and I'm audible.
Yes, Aditya.
Yeah, okay, great. So I will skip through most of the data initial slides which I have. We all know lung cancer is a huge problem. It's the same all across the world as it is in India. In India, this is the most commonly diagnosed cancer. And unfortunately, this is the leading cause of cancer deaths, which accounts for nearly 18% of all cancer deaths. Globocon 2020 data came out a couple of years back, and this did highlight a lot of things which we thought weren't happening in India. People always thought that oral cancer was the biggest burden amongst Indians, but it does turn out that lung cancer is also equally big. 8% of all new cancers diagnosed in 2020 were lung cancers. That translated into an absolute number of about 50,000. We do know that this is the tip of the iceberg, and most likely the numbers are going to be far more than what we have right now, what the data does say over here. Quite unfortunately, 66,000 deaths happened due to lung cancer in the year 2020. So what do we need to do to change these statistics? How can we make our patients do better? Using the best drug first will maximize the benefit to all EGFR mutant patients of us. And this is the change in the treatment paradigm, or rather the change in the philosophy which oncology has undergone in the past decade or so. What are the first line options that we have? Just like we have a 2G, 3G, 4G, and now a 5G, we have first gen, second gen, and third gen, with varying pros and cons of use in the first and second line. So let me start by talking about how important it is to have a third generation inhibitor like osimertinib in the first line. Let me just start this point by saying that osimertinib has been given a preferred or a category 1 recommendation by NCCN for patients who have a EGFR mutation in advanced non-small cell lung cancers. How is this different from the second and the first generation drugs? What I want us to pay attention on is that osimertinib is a third generation inhibitor, and it has a irreversible binding to the EGFR receptor, whereas the first generation binding is basically reversible. So that is the first big difference. The second big difference is that EGFR has a significant ability to cross the blood-brain barrier, and that does make a lot of difference. And all of this is purely because the targeting is actually the covalent modification of the ATP binding site, which is cis 797. However, when we look at the first generation inhibitor, the actual site of binding is a reversible binding to the EGFR ATP binding site. A little bit about what second generation TKIs do. Afatinib is our second generation TKI, and apart from binding at the cis 773 binding site, it also does bind at the HER2 or the cis 805 site. So osimertinib is an irreversible CNS active EGFR TKI, which has been developed to selectively target both EGFR sensitizing and the EGFR T790M resistant mutations. And as you can see from the animation here, the drug not just binds to the commoner exon 19 and the L858R deletion, it also does bind to the T790M mutation site as well. This leads to inhibition of the T790M mutation. However, osimertinib does not have any activity in the wild type EGFR, and this does cross the intact blood-brain barrier, and this has been seen in human and preclinical models. And the translation of this bench-side science was demonstrated in the path-breaking FLORA trial. This was a phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TKI as the first-line treatment in patients with locally advanced or metastatic non-small cell lung cancer. So, interestingly, FLORA chose a primary endpoint of PFS and a secondary endpoint of overall survival. So FLORA was a straightforward shootout between osimertinib, which is the third generation TKI, versus geftinib or erlotinib as the standard of care treatment arm. Patients included all treatment naive patients, and significantly we have to note that stable CNS metastasis was also allowed. Patients with exon 19 deletion 7 deletion 19 and L858R were the other inclusion criteria. So patients were stratified based upon the site of mutation and the actual race. This study also allowed for crossover. And I'll talk about the significance of this a little later. So as far as the curves go over here, the KM curves show such a early separation. The separation was as early as 6 weeks. The median PFS was nearly 19 months with osimertinib versus about 10 months with first generation TKIs, and PFS is a direct measure of the drug benefit. FLORA was powered to determine whether PFS benefit was a significant benefit or not, and it had an astounding hazard ratio of 0.46, which was statistically significant. These forest plots we almost never see, coming from our own era, wherein we looked at chemotherapy trials in a metastatic setting. We would never see a forest plot wherein every single subgroup significantly favored the experimental arm over the comparator arm, be it somebody with a smoking history, be it somebody with a CNS metastasis, be it somebody at any EGFR mutation site. And interestingly, EGFR mutation, even if it was confirmed by a liquid biopsy or circulating tumor DNA, even across all of these subsets, osimertinib definitely did better than the first generation TKIs of geftinib or erlotinib. Overall survival, and this was presented in 2019 ESMO, and I was a part of this path-breaking talk, which was given in 2019. The hall was full, and everybody was waiting with bated breaths, and all of them did get their more than their money's worth. This was the first time that in advanced non-small cell lung cancer, a median overall survival of more than 3 years, that is 38.6 months, was demonstrated in a trial which was actually powered to look at overall survival. Osimertinib patients were more likely to be alive both at the 2 and the 3 year landmark, and this was the first time an EGFR TKI has translated a PFS to a significant overall survival benefit. Nearly 30% of the patients were still receiving osimertinib at the 3 year mark. Very importantly, what was the time to first subsequent treatment? And more often than not, the first subsequent treatment was going to be chemotherapy. And we all know that when we talk to patients about chemotherapy, that definitely does translate into a worsened quality of life. So if we could improve the quality of life and keep it such that for a prolonged period of time, that also does make a lot of difference during the treatment lifetime of our patients. So in osimertinib, the median time to first subsequent treatment was more than 2 years. When somebody went on the first generation TKI, it was just about half of that at about 13.7 months. Again, hazards were very significant, was 0.47. So osimertinib provided unprecedented improvement in the FLORA trial. And when we look at various subgroups, be it on the PFS or in the OS, most of the places the PFS subgroups did show a significant benefit in the forest plots. When we looked at overall survival across most subgroups, although in some of them it was not very significant, across most subgroups the overall survival was also significant. So osimertinib's PFS benefit was clearly maintained consistently across all subgroups, demonstrating its superior benefit across all population, including by race and across the different mutation types. All OS subgroups showed a positive benefit in favor of osimertinib, although the magnitude of benefit actually varied, and this is consistent with the PFS data of other subgroups. Now, let me jog back to how the first generation TKIs fared, and this slide is one single snapshot of how geftinib or erlotinib did, and this is real world data collected from Indian patients. So we know that studies done in Tata, the study 1 and study 2, they did show the overall survival of about 6 months to 18 months. Robert Lewis did a study of which I was also a very small part at ADR, and then in a very small subset of about 48 patients, the overall survival shown here was 10 months. Dr. Vanita Naronia, again the path-breaking author of the PEM-carbogeftinib trial, her team did show overall survival of about 21 months, but this was the maximum overall survival shown for any Indian study with first generation TKI. And when we compare this with the overall survival of 38 months with osimertinib, there is basically no comparison at all. So how about sequencing? What if we try and put a second generation TKI and then do osimertinib? So this slide talks about a straight shot comparison of what the Archer showed and what Flora did. Archer was a straightforward combination, straightforward study which compared dacometinib as the experimental arm versus geftinib as the comparator arm. We need to note that erlotinib was not one of the comparator arms. However, Flora included both geftinib and erlotinib in their comparator arms. When we look at the inclusion-exclusion criteria of Archer, did exclude patients who had any CNS metastasis, be it stable or unstable. They excluded all of them straight away. Again, if anybody had a history of suspected or diffuse non-infectious pneumonitis, they were straightforward excluded in the Archer trial. Flora included patients who had a stable CNS metastasis. So we can see that, by these curves, although there was a PFS benefit in the dacometinib study, we know that the actual benefit was seen only by about 6 months after being on the study drug. So the separation of curves happened at around about 6 months period. We do not, and if we have to counsel our patient in the OPD tomorrow and say that you need to wait for 6 months before we see a difference, although you pay more for this drug rather than the other drug, patients will end up questioning us. However, when we talk about osimertinib, the separation was almost immediate. The separation was as close as 6 months, as close at the 6-week mark only. We knew that it did far better than the first generation TKIs. So overall survival was not statistically significant because the way this trial was set up was that it was a sequential analysis of all the survival data. The minute the overall response rates did not become significant in Archer, overall survival could not be statistically computed over here. However, in Flora, for the first time, an EGFR TKI has translated PFS to a significant overall survival benefit. This is some real world data which was published in 2020. This looked at the Canadian consensus study, and then this trial showed that because the Archer trial had a hierarchical stratified statistical design, and there was no significance in the overall response rate, a p-value actually could not be given to overall survival. So just to completely compile what I discussed in the last 3-4 slides, the dacometinib landmark trial had a KM curve which separated at 6 months, whereas Flora had a KM curve which separated at 6 weeks. The overall response rates was not significant in the dacometinib study, and overall response rates in osimertinib were very significant. Dacometinib was an open label study, however Flora was a straightforward double-blinded study. Significantly, no CNS or leptomeningeal mets were included in the dacometinib study, and Flora did include all patients with stable CNS metastasis. The final word about any study drug is how tolerable it is for our patient. Nearly 2/3 of the patient who went on the Archer study needed some kind of a dose reduction. However, when we talk about osimertinib, only 3% of the patients needed some kind of a dose reduction. When we talk about the other second generation TKI, which is afatinib failed to improve overall survival versus just in the LEX-Lung-7 trial. So and that is no longer even a standard of care in first line when we talk to our patients. So this is basically a cross trial comparison, which we generally should not be doing. But when we try and compare LEX-Lung-7, Archer, and Flora trial, the most important thing is how soon am I going to get better, doctor? That's what our patients ask. And to answer that question, if my patient is given afatinib, they will get better at about 12 months. If they are giving dacometinib, they will get better at about 6 months as compared to geftinib. However, if they are giving osimertinib, they'll get better within 6 weeks as compared to geftinib or erlotinib. The final part of my talk is about brain metastasis. I will not spend too much time on this, primarily because Dr. Ullas has gone through all of this. Very importantly, osimertinib has demonstrated high brain penetration in FLORA. Both systemic and intracranial efficacy were analyzed. Osimertinib showed superior efficacy. Osimertinib is the only EGFR TKI to report intracranial efficacy till date. This slide looks at the KN curves and CNS progression events in patients who had known or treated CNS metastasis. Across both these subsets, the hazard ratios were quite significant at about 0.47 and 0.46. When we looked at the intracranial PFS and the full CNS analysis subset, the intracranial PFS for patients who went on osimertinib was not even reached, as compared to 13.9 months when somebody took the first generation EGFR TKI. So we know that if somebody has been newly diagnosed with brain metastasis, and even Dr. Sahu had to concede to this, patients with EGFR mutation who had brain metastasis upfront and who had NSCLC as a primary tumor, osimertinib does automatically become the first line treatment choice. We know that as far as tolerability goes, osimertinib had a fantastic safety profile. Only 3% of the patients on the landmark trial had to undergo some sort of a dose reduction. So all of this talk about the same as compared to the Lux Lung 7, wherein about 42% of the patients who went on afatinib had some dose reduction needed, and about 2/3 of the patients on the dacometinib trial, which is the Archer trial, who needed some sort of a dose reduction. When we talk about patients in the geriatric age group, and in India, many patients, unfortunately, with non-small cell lung cancer do qualify under this. There was a higher incidence of grade 3 and grade 4 adverse events, with a more frequent discontinuation rate with dacometinib. So essentially, what is the synopsis of why we think it is important that patient receive osimertinib in the first line? And this slide has been discussed and dissected fairly frequently in the last couple of years. Just to reinforce one single point, 1/3 of the patients already have T790M at first progression, so they straight away do not they straight away end up benefiting with osimertinib in the second line. But what about the other 2/3 of the patients? 1/3 of the patients who receive first generation TKI in the first line do not end up getting any second line therapy. So that is straight away 1/3 of the patients who do not get a benefit of the better drug. There will be 1/3 of our patients in whom we will not know whether the patient has T790M or not, and unfortunately they too might not end up getting osimertinib. So it is very important that if we have a drug which we know is better than what we are using currently, we need to offer it to all of our patients and not risk even 1% of them not having a shot at getting a better drug, let alone 30% of them. So geotag is the final of my talk. Geotag is something that even Dr. Batra discussed quite a bit about. I will finish very quickly. Sequencing of, when we talk about EGFR, sequencing of EGFR TKIs, starting with prior generation EGFR TKIs and then treating those that develop EGFR TKIs with osimertinib is not optimal clinical care, purely because we are not smart enough to figure out who will get the EGFR T790M mutation, number one. Number two, not everyone will be well enough to receive additional treatment, and 30% of patients in both arms received no subsequent therapy. Tissue or liquid biopsies are not always successful, and above all, we need to give overall survival has to be the main aim for any patient with any cancer for a medical oncologist. And all of this data confirm that osimertinib is the first line standard of care in patients with metastatic EGFR mutant non-small cell lung cancer. I like to thank AstraZeneca for generously agreeing to sponsor a part of this lung cancer event. I like to stop my talk over here and happy to take any questions.